And so it gives me great pleasure to introduce the first speaker, Dr. Andrea Russo, who is the Director of Electrophysiology and Arrhythmia Services and the Director of the EP Fellowship Program at Cooper University Hospital. The topic of her presentation today is the latest in ICD therapy. Glad to have you.
Great, thank you. Thank you, Sana, for inviting me to this wonderful meeting and great turnout for one conference in Philadelphia. It's hard to get so many people in the same room, so I think it's really says a lot about the organization of the meeting here. Let's see, how do I get to my slides would be the real question here. Is there something?
Actually, you need to end mine.
Let's see, how do we do that? I'm sorry here. Okay. This way?
Yeah, I think.
And as they're getting the slides up, looking at the objectives of the program, one of the important concepts brought up related to defibrillators are looking at the evidence that we have out there now. And this is one of the areas where we really have a huge body of evidence from multiple multi-center clinical trials. And how we've been hearing a lot of, sometimes bad publicity about defibrillators. So I wanted to spend some time, and I know a lot of people in the room may already have seen some of this data, but going through some of the information that we already have today with the clinical trials. I'll start out by just telling you a little bit about the epidemiology of sudden cardiac arrest. There's some historical things about defibrillators, then talk about the data that we have from these clinical trials for primary and secondary prevention of sudden death, and how we got to these guidelines. And some of these, high level of evidence studies have led to guideline development. Talk a little bit about some of the features of devices. I know the people in the room aren't going to be the ones programming the devices, but just to give you an idea of what we have now related to this great area of technology. And safety and reliability of devices mentioned in some advances in technology. What I didn't do in the beginning, and I'll show you here, my potential conflicts of interest. I don't know if I can go back, but I will tell you that I do participate in clinical research trials from multiple companies, including Medtronic, Boston Scientific, Biotronic, and Cameron Health, and also give speaking engagements with some of with these same companies. It is listed on my first slide, but I went through that quickly. So overall, the incidence of sudden cardiac death by age and sex, going back to the Framingham study, which we see over and over again, you could see there's an increased incidence of sudden death in both men, shown in green, and women in pink as you get older. And at each age group, the incidence of sudden death is actually higher in men than in women. And there tends to be like a 10 or 20-year lag in women compared to men. So, and as we have an aging population, we're going to see more and more of this, and some of it can be prevented. This is just a schematic by Bob Meyerberg that kind of shows the estimates of incidence in % per year of sudden death, and the total number of events per year. So you could see here that overall in the population, the incidence, although it may be decreasing, of sudden death is down at 0.1 to 0.2%. When you start to get into these higher risk groups of patients, the incidence increases. So you have a lot of events occurring in some really sicker patients. And when you look at the primary prevention, so preventing the first episode of sudden cardiac arrest or preventing sudden death, we tend to focus somewhere in here. Patients that have some underlying structural heart disease may have a low ejection fraction somewhere in the 30s to 40 range, or may have already been even higher risk and have already had a cardiac arrest. Those are some of the studies that you'll see shortly. Now, when you look at modes of death in patients who have congestive heart failure, this is a beta blocker study. You can look at the functional class. So if you're class 2 or class 3, the red here is the sudden death. The mode of death in these patients was sudden in about 60 or so % of those who died. Whereas if you're a class 4 patient, the mode of death is more likely to be from congestive heart failure. So you can imagine, as you're looking at how these trials were designed, If you're going to look at a study that looks at primary prevention of sudden death with a defibrillator, you're going to want to focus on these patients because you need less patients for the study, and also you could show more of a benefit potentially in this group. Whereas you'll hear later today, one of our speakers will talk about heart failure therapy with cardiac resynchronization devices. You'll focus more on these sicker patients, these people who are more likely to die from heart failure, the class 4 or even potentially class 3 patients. And then where do these numbers come from? Well, people didn't pull them out of a hat and say, well, we're going to pick 35 or 40%. There have been studies, and this is just one of them, in the pre-thrombolytic era, shown in the clear bars here, and the black bars are in the post-thrombolytic era, that if you look at overall cardiac mortality, this is here, that when your ejection fraction gets less than 40%, it seems like, and particularly when it's less than 20%, as you'd imagine, the chance of dying is much higher. So you'll see most of the studies tend to use 35 or 40% as a cutoff for enrollment criteria. So just a little history here, and this is maybe before the time of many people in this room. I unfortunately was around, not during the very first defibrillator, but shortly thereafter. This was the first device was implanted in an abdominal region. In this case, it was an epicardial system. This was a patch placed on the heart, so patients needed a thoracotomy. One coil was in the SVC high rate atrial junction. And then also there was a technique to use 2 epicardial patches. So these were performed. It was a big procedure performed in the operating room by the CT surgeons. We've come a long way. Initially, in the early 1990s, was approval of the first endocardial lead, like a pacemaker lead. At that time, it was tunneled to the abdomen. This here shows you a device that's implanted in the pectoral region. And you may or may not be able to see from the back of the room, but there are 2 coils in the heart. Here's one in the right ventricle. Here's one at the SVC, high rate atrial junction, and the shock was delivered between the 2 coils. Advancements in technology have now allowed us to have active CAN devices so that the defibrillator itself is part of the circuit. So when the patient has ventricular fibrillation, shocks can be delivered between the coils and the CAN, and that's referred to as an active CAN. So just a little bit about secondary prevention. This is something I think we take for granted now, but when the studies were being done, and we had actually been one of the participating centers in AVID, which is the United States, was performed, sponsored by the NIH, performed here in this country, antiarrhythmic drugs versus ICDs, although we assumed defibrillators would reduce sudden cardiac arrest or sudden death. The question is, are they dying from other things? Are we really impacting on total mortality? So these were trials that were done. This one was in Germany. This one was in Canada, and trying to look at overall survival. And I'm going to show you here, this was basically randomizing antiarrhythmic drugs versus ICDs. The antiarrhythmic drug in this particular trial was really amiodarone. Some people got Sodol, but mostly amiodarone. Here you'll see survival. I'm sorry, and I will go back here. Let's see. Survival on the y-axis, and time in years on the x-axis. You could see that patients who received defibrillators did better than those who received antiarrhythmic drugs. And in fact, and I remember this was very earth-shattering at the time, back in 1997, that the study was stopped prematurely. And you'll see this pattern in some of the slides I'm showing you. And so basically, I'm going to show you all the good data we have regarding defibrillators. And so this is just secondary prevention. I won't show you the other studies in particular. Now, they were designed a little bit differently, but clearly AVID was the largest study. Enrollment criteria includes sustained ventricular arrhythmias. The Canadian trial also included syncope, which may have impacted on some of the results. They did not get a significant reduction here in overall mortality, but again, this may have been, the way it was including the syncope patients may have impacted on the power of the study here. But pretty much, the ejection fractions were pretty low in these studies, not so low in this study. But the other thing I want to bring your attention to, and you'll see later on in the primary prevention trials early on, beta blocker usage in patients who were in either arm, ICDs or amiodarone. And this is well after the beta blocker trials came out, the benefit of beta blockers in reducing sudden death. But you could see that it was pretty poor here. And so just to give you an idea, and then someone came by and did a meta-analysis.
Andrea, let me interrupt. Let me ask you, wouldn't you say that the main reason why CASH and SIDS did not show a significant improvement in survival with an ICD had to do mostly with the sample size. I mean, they were much smaller than AVID, and I think that's a point that we absolutely have to emphasize.
Yes, yes, and I apologize for that. I should have actually pointed out the numbers here. Look at the N here, 191 patients. That's, Dr. Al-Khatib makes an excellent point. That is the main reason why. And in here, again, the study design was very different. Patients actually could not get beta. It was designed not to give patients beta blockers. The design was different. The EF was different. But I agree. The main reason is that just a really low sample size. So this was the largest study. And if you did do a meta-analysis, you did see both in overall mortality and in arrhythmic death. In the meta-analysis, as you'd anticipate, there was a significant reduction in overall mortality with the defibrillator. And this was basically pretty much related to a reduction in arrhythmic death. And if you look at the overall numbers, the annual death rate was 12.3% compared to 8.8% in the meta-analysis. And again, remember the timing of this too. A lot of these patients received thoracotomy devices, had their chest open, had a big procedure. And if you look at that data, patients treated before the availability of these transvenous devices, a higher risk procedure to open up their chest, had less benefit than if you were treated with transvenous or non-thoracotomy devices. So all those things, but I think I agree the sample size is the main reason. So again, since this is a very evidence-based conference, I really wanted to show you what the guidelines say for device-based therapy and for secondary prevention. And a lot of us take this for granted now, but this is a class 1 indication for an ICD. Survivors of cardiac arrest, or if you had sustained VT that was hemodynamically unstable, ICD therapy is indicated, and that's a high level of evidence, A. Also a class 1 indication if you have structural heart disease and spontaneous sustained VT, whether it's stable or unstable, it's considered a little lower level of evidence because most of the trials didn't have that as an enrollment criteria. And a 2A indication that it's probably reasonable for patients with sustained VT that don't really have bad hearts. But the benefit, and I didn't show you the data, but the benefit was greater in patients who had low EFs than if they had more preserved EF. So that's the history of secondary prevention. Now the primary prevention trials, I'm going to show you some data on that. These first 3 here are looking at patients with coronary disease. Initially we had most data with coronary disease patients. Definite is a trial that looked at just non-ischemics and the sudden cardiac death. This is really kind of revolutionized. This is NIH-sponsored what we do for treatment of patients. This was half and half, coronary disease, non-ischemic. And companion, I'll mention briefly. I suspect later on you'll hear more about CRT therapy, but this was a primary prevention trial that also included CRT. And just conceptually, the first 2 trials we'll talk about, the first made a trial in MUST. We in EP initially would bring people to the EP lab, and one form of risk stratification, and older studies had shown that if you have inducible sustained ventricular tachycardia, so you bring them in the lab and you give them 2 PVCs here, you can induce this arrhythmia based on this fixed substrate. And then we try to suppress it with drugs. So the concept, and again, the timing of the first 2 trials included EP testing. And if you were no longer inducible on drug, that was considered a good response. Again, this is the first trial. You're going to see a pattern here, prematurely terminated. Another one because of the benefit of defibrillator therapy. This made it trial was just coronary disease patients, as I mentioned. You had to have at least 3 beats of non-sustained VT, never had syncope or cardiac arrest, and a low EF. The cutoff here was 35%. This one used EP testing. And you could see the benefit of defibrillators, and it was stopped after just 196 patients were randomized. So this was a really high-risk group of patients. Now, in the conventional therapy group, the one thing to point out is that the mortality rate was actually quite high, and there was some thought that perhaps whatever people considered conventional therapy at the time was allowed, that this was a company-sponsored trial. It wasn't really a control group per se. Some of these patients did receive antiarrhythmic drugs, and there could have been certainly some pro-arrhythmia related to that. So you'll see as the pattern, as we go on, the studies have a little bit different type of enrollment criteria and different randomization scheme. This was the multi-center unsustained tachycardia trial. Again, with coronary disease patients, this was sponsored by the NIH. And the cutoff here was an EF of 40%. And again, the risk stratification included EP testing in this group. And so if you had inducible VT, you were allowed to be randomized to either receive EP-guided therapy or control, which is standard, not antiarrhythmic drugs, but standard heart failure therapy, beta blockers, ACE inhibitors, things like that. This here, now it's events on the y-axis instead of survival here, but the events, this is the control group. This is the EP-guided therapy group who received a defibrillator, had a significant reduction in events, but if they got antiarrhythmic drugs, that was serial antiarrhythmic drug trials using EP testing to prevent inducibility, they did not benefit. This actually was not any worse than this statistically, but you could see that it looks like it, you didn't do any good for sure, but the only patients who benefited were those who received an implantable defibrillator. The next MATA trial, so everyone said, well, EP testing is kind of, we don't really want to, we don't have it available everywhere. Let's do a trial without EP testing. This was a company-sponsored trial, a large trial though, MATA-2, which looked at over 1,200 patients. Again, never had any sustained clinical arrhythmias, primary prevention of sudden cardiac death, coronary disease only. EF cutoff here was lower, and they didn't even have to have one PVC. There was no requirement for ventricular tachycardia, although I suspect with that EF, patients did have ventricular ectopy, but it wasn't required as one of the enrollment criteria. Here is survival, and you can see here that the study was terminated again, showing because of the benefit of defibrillators, things would start to separate at about 9 months. And you can see that patients who received a defibrillator had a markedly better survival than those who received just conventional therapy. And this benefit, again, on subsequent analysis, was due to the prevention of sudden cardiac death, as you'd imagine, because defibrillators probably save lives through prevention of sudden death, at least single-chamber defibrillators, and that's what these were mostly. So now the first non-ischemic trial that was published was a very small trial. You can see here really under 400 patients, and they were looking at a variety of things. This trial included patients who had an ejection fraction of 35% or less, and they didn't really have to have severe heart failure class 1 to class 3. And here, one of the surprises was that at this point in time, actually the mortality rate was relatively low compared to at least what you saw before, but 14% mortality rate, 7% mortality rate at 1 year, 14% at 2 years. So again, this was not statistically significant benefit of the ICD in terms of survival. It did have a significant benefit in preventing sudden cardiac arrest or arrhythmic death. But again, here, the power of this study is a much smaller number of patients and a lower than anticipated mortality in the control group. But here was really the late breaking, the big trial. The sudden cardiac death and heart failure trial, Definite was sponsored by a device company. This was NIH-sponsored, extremely well-designed trial looking at not just defibrillators. There were 3 arms to this trial. For primary prevention, again, never had sustained VT, never had an sustained arrhythmic event. Patients were randomized to either amiodarone, ICD, or control here, placebo. And this is for ischemic and non-ischemic, and it was about a 50-50 breakup, 50% ischemic, 50% non-ischemic patients. The EF cutoff here was 35%, and class 2 or 3 heart failure. So again, most of the trials, as you see, the risk stratifier for most of the trials, or all of them, had an EF cutoff that was either 30 to 40%, somewhere in that range. Some of them also required some heart failure for criteria for risk stratification. This one was class 2 or 3 heart failure. And you can see here that here's the yellow is placebo. The green is amiodarone, so that was no significant difference compared to placebo, but there was a significant reduction in overall mortality with ICD therapy here. There were some subgroup analyses. Again, we are always hesitant to look at the subgroup analyses. These were not all pre-specified subgroups, but there were there was a lot of talk of should we have a lot of patients out there who would be have criteria for these studies. Should we try to exclude and just look at the highest risk group of patients? And one of the earlier trials, what made it, people were saying, well, people wire QRS have more benefit, and that's probably true, but again, that's a retrospective subgroup analysis that, we need to have caution with. And there was even a lot of talk here, women, we have women here. It seems like men benefit more. Here's ICD better on this half. Men seem to have more benefit. This one crosses, crosses over here. But remember, this was not powered. There were and I didn't point out in other studies, but in most of the studies, particularly the coronary disease trials, there were very few women enrolled. And so very few women got defibrillators, so we don't really want to say much about that. It was really underpowered to show a benefit of ICD therapy in women. And there has been a flurry of articles in that area. Dr. Al-Khatib's interested.
I certainly want to comment on that, Andrea. So many of you might know that there have been a few publications lately concluding that women actually don't seem to benefit from ICD therapy. And let me get your thoughts on that, Andrea. As you pointed out, I mean, it's clear that when you look at the epidemiology of sudden cardiac death, that the risk of sudden death is lower in women than in men, but it's definitely there. And so even when you do meta-analyses of these big clinical trials, the fact that very few women were included in each trial to start with, even with a meta-analysis, I don't think you'll actually achieve enough statistical power to show an improvement in survival with an ICD in women, because if you look at the data, you actually need to have more women than men to be because the risk is lower in women. You need to have more women than men to be able to show survival benefit. So how do we go about educating other physicians, non-EPs about this? Because there's a lot of hype in the media that ICDs don't work in women, and I worry that some people who don't really look at these studies very carefully may take that at face value and start, either stop referring their women patients or female patients for an ICD, or change their practice in some way. What are your thoughts about how we can go about educating the average physician about this, and what do we do to actually get the data?
Yeah, I think that is a really important point, and I actually also had the opportunity to go back and look at, with Scudheft and with Must and with another clinical trial, really, even if to power, and actually we did have some of the statisticians through Duke look through and see how many women we would have need to enrolled in Scudheft if there were an ICD benefit specifically, and it would have been way more. The trial would have had to been much larger in just women, and talking about somewhere on the order of 3,000. So we're really clearly underpowered, and I think some of the efforts, and actually some of the efforts you have taken, and through Duke, some of the even educating our own community. It's not even out there yet in the public. We need to educate the public, but educating our own physicians in not so much electrophysiologists, but also general cardiologists. There is an effort, as Dr. Al-Khatib has initiated with some of the other people at Duke, is a sudden cardiac arrest awareness initiative, a Thought Alliance initiative to look at this. So I think we need to be out there in the media. Unfortunately, we need to educate, or do conferences like this, educate our primary caregivers out in the community, out at university centers, to let them know this is just subgroup. It's kind of a hot item. It's a sexy item. Gender things, racial differences, things like that. But really, we look at the characteristics of women, and the women, they're a little bit different when they get into clinical trials. So I think we just need to push on. We need to have those educational efforts in this kind of format, but also I think we need to do something in the media, because women need to be more aware. Thank you. Yeah. So I'll just briefly show you the companion result, and I suspect you'll see something of this. This was a trial, the only one of the primary prevention trials looking at, in this manner, randomizing to optimal heart failure therapy versus the optimal heart failure therapy with a CRT pacemaker. That's an extra lead in the coronary sinus to help resynchronize the LV and improve heart failure, or that with an ICD. And this was also ended early after 1,500 patients because of the reduction in mortality here with the ICD arm. So I'm going to just summarize all those results: percent mortality reduction through all the different trials. Again, depending on what you use as your risk stratifiers for enrollment. Maybe with the EP testing, we really pick those higher risk group of patients. that didn't respond to drugs, and EFs obviously have some impact on that. But there was a reduction in mortality in all these trials, and if they were powered for this, it was a significant reduction in those that were powered. So, and this is just to point out the time frame of when all the trials were done, the biggest trial, and Dr. Al-Khatib pointed out early on, you got to be careful. Look at the numbers, small numbers in some of these studies earlier on, and the follow-up duration. Not only was it the largest study, it had the longest follow-up, and also it was real life, because now we're really using beta blockers and ACE inhibitors here the way we should. Look how bad we did back here, and it was quite amazing to just look at those low percentages of drugs we know help reduce mortality. So that's where we are today, and so we do have lots of data, and this is in this area. It's really good. Multiple multi-center clinical trials showing the benefit of ICDs, and so we can't forget that when we hear about something in the media that sounds not so good. And again, we need to do better. I'm not going to go into it, but we need to do better at risk stratification. EF is probably not enough. Maybe we need some other multiple non-invasive risk stratifiers, or maybe we need to use genetic testing, hopefully eventually to be easy, because we want to get that Myerberg, that first schematic I showed you. We want to get more people, not just the people we know are at highest risk. How do we know who's going to die suddenly? There's some data coming out with use of cardiac MRI to try to see how much scar is there. And so EF is probably not enough, but also I want to show the other side of it is that very early post-infarct, and this impacts on the guidelines too. If you're very early post-infarct, an ICD is not indicated, and that's based on this one trial called Dynamite, also sponsored by a device company and also supported by a sub-study analysis of the MADIT data. Let me just show you Dynamite. This is very different than the other primary prevention trials I showed you, because they usually excluded people very early post-infarct. Here, these patients had a recent MI as soon as 6 days to 40 days, and that's where that 40-day number comes in the guidelines. Their EF had to be 35% or less and had reduced heart rate variability. There's a sympathetic parasympathetic influence on the sinus node that affects your heart rate. But you can see there was no difference in mortality in this particular trial with an ICD. Patients died of other things, and so that's not the time to get them. And this is actually supported, and you would think, at least on the surface, you think, oh, and I hear this all the time, actually, from referring docs, the patient had an infarct 5 years ago, he's lived this long, he's fine. Well, actually, if you look at the MADIT data, MADIT-2 data, this is overall here, you can see the benefit of the ICD is greater when you were further out after your infarct, greater than 18 months, and then if you were enrolled closer to the infarct. So they're not safe. The bottom line is that scar can mature and and develop arrhythmias many years down the line. It may be 5 or 10 years or more in some cases. So don't think they're safe because they've lived to that point.
Andrea, I'd like to point out, though, that when you look at this analysis, obviously it was a secondary analysis. I don't know if it was pre-specified. It is important to note, though, when you look at this slide, that most patients enrolled in MADIT-2 actually were more than 18 months after NMI. So if you look at this subgroup of people who were enrolled within 18 months of NMI, that group was actually relatively small. And so that actually begs the question as to whether if you were to include a bigger sample size, whether that may have changed the results. Now, granted, I agree with you that Dynamite showed no benefit. There's another trial that was recently published, the IRIS trial, that was mostly European, actually confirming the results of Dynamite. So clearly there is a signal there, but I wouldn't put too much weight on this secondary analysis. What do you think, Andrea?
Yeah, no, I agree with that, and I wasn't actually showing this to say we shouldn't do it early on. I was just trying to support the Dynamite data, but you're right. Most patients were more stable out there. It's more to point out that, at least I've heard, and maybe not necessarily everyone in this room, but I've heard over and over again, they had their infarct when they're 45 and now they're 60, they don't need a defibrillator. But that's not true. There's all these patients that have been doing well for so many years, and those are the people we want to save, right? They're doing so well. They're not in and out with heart failure all the time. They're really doing well. So the point is, and this is, again, subgroup analysis I actually hate, but it was more to support to go ahead and don't exclude them because they're further out, because I think people were doing that. But I agree 100% with Dr. Al-Khatib on that. And so here is how those guidelines come out. So these are the written guidelines for who do we put devices in for primary prevention. And we recommended class 1 indication, very high level of evidence, all the trials I just showed you. EF is, and again, the cutoff was somewhere between 30 to 40% in all these trials. With class 2 or 3 heart failure, class 1 indication. Class 2A, it's reasonable if they have class 1 heart failure, because there were less studies that included. SCUD-HEF was class 2 or class 3. So you could, it's still not as high a level of evidence here at B, but it's still indicated in those cases. But the highest level here is with those who have class 2 or 3 heart failure. And for the non-ischemics, we talk about the 35% cutoff, because that's the studies looked at 35% or less, and we want to do it if they have class 2 or 3 heart failure. Again, a lower level of recommendation here if they have class 1 heart failure. And then the CRT you'll hear more about, but basically to say, because of companion at least that I showed you, wide QRS and they have bad heart failure, class 3 or 4 heart failure, a device for primary prevention would be indicated. So I want to actually switch gear and just give, because there are, I know, different levels of experience out here in the audience, but the devices, and even in the time that I've been in this area of electrophysiology since, I guess, practicing since 1992, the technology is just incredibly advanced, and it's just amazing. Not only can we see all the things we see with pacemakers, look at the impedance, look at your battery, test your thresholds, things like that, but we could actually see the intracardiac signal, the rhythm that led to the therapy, and the outcome. So we have this vast body of data and information on particular patients and out there on all our patients with defibrillators. There are also a lot of features, and I won't go through in detail here, but a lot of features within the devices that help us discriminate between supraventricular arrhythmias and ventricular arrhythmias. And because of that, we can reduce what we call inappropriate shocks. Inappropriate, the device works the way we set it. So if we set it for a rate of 170 beats a minute and you have atrial fibrillation at a rate of 180, the device is going to treat it by rate. But there are other features that help look and distinguish the two different rhythms. And one of the features is to look at intracardiac electrogram morphology. This is just a signal from the RV lead, what the device sees, and you can see this rapid rhythm that looks pretty much identical to the supraventricular rhythm, the sinus rhythm. So the device can calculate all this, and it's quite amazing, and look at the percent match, and uses a lot of different ways to do this, to the intrinsic rhythm. It also can look at regularity, irregularity, how is it a sudden onset, is it a gradual onset like sinus tachycardia. So there's all these great features in devices nowadays. In addition, if you have a dual chamber device, this is ventricular tachycardia. Here's the atrial lead. Here are the atrial electrograms or the P waves. Here are the ventricular electrograms, and you can see if you're looking at your surface lead, your V's are dissociated from the A's, and the devices can calculate that. So the device knows this is ventricular tachycardia. Don't waste time and deliver therapy in some way. One of the ways we can deliver therapy is with anti-tachycardia pacing, a painless therapy. And so the patient goes into VT. This was just a telemetry strip and didn't even know he really had it. The patient may have some palpitations, but very nicely the device sees it, calculates a percentage of that rate, and paces a little bit faster, and then terminates the rhythm. Very nice. And so I mentioned a little bit, and then people hear, again, you hear these stories and oh, we got all these inappropriate shocks, but really our features in our devices help us to reduce the frequency of inappropriate shocks. We're not perfect yet, but we hope to be soon, or close to it. So here we can detect atrial fibrillation, other forms of atrial arrhythmias, or sinus tachycardia, particularly in young patients. You want to be really careful, and part of this is when you program these devices, you need to know what you're doing. You need to not just program out of box in every patient, but if you have a young and very active patient, you want to make sure that you program that heart rate really fast. Because they're going to do activity, they're going to run, they're going to do things like that. You may want them on a beta blocker. You may want to do an ECG stress test to see how fast they can get their heart rate up on your medical therapy. And on occasion, we do have lead problems, but the devices can see this, and we can actually see it when we look at the electrograms. I'll show you an example in a few minutes. So the initial studies, again, before we kind of knew about this, before we had all these features, we can really get an inappropriate shock rate that's quite high. Now we're more careful on how we program that rate cutoff. We put people on beta blockers if they need it. And we have all these enhanced diagnostic algorithms within the device that the companies have developed, the engineers have developed to reduce inappropriate shocks to less than 5% in most cases. So I want to just mention a little bit about the ICD registry. It's the NCDR registry, and people say, we talk about, oh, devices are scary. Are they really, they're doing what we thought they do based on the trials? And actually now we have this really, really great tool that was actually developed by CMS required us to enroll patients who had primary prevention. Everyone was afraid, oh, this is the cost of health care. We're going to spend all this money on devices. So for patients who had required primary prevention ICDs, it was required that they get enrolled in this registry. And this is just some data from the second year of the registry, looking at over 206,000 implants at many hospitals in the United States. And most centers, by the way, have been enrolling all their patients in this registry, which initially just included device data. Now it's going to actually include, it currently includes lead data, so we'll have some data on the performance of leads down the line. But you can see here, the in-hospital complication rate is actually relatively, relatively low in terms of severe complications. Death is 0.02%. Cardiac perforation is, again, these numbers are relatively low when you're talking about a surgical procedure, lead dislodgement, and these are in-hospital rates. Again, maybe if you include out-of-hospital rates, you may get you'll pick up some down the line. But we're, at least acutely, the data looks pretty good. And I had to kind of show this too, that in everything we do, whether we're doing cath and stents and in doing device implants and doing ablation, which we'll hear more about, operator experience, and not just the operator, it's actually really, EP is really a team effort now. It's the whole team in the electrophysiology lab, in the outpatient office, this particular study by Dr. Curtis stratified patients by type of implanter. And those who were I know you probably can't really read these numbers, and I apologize, but if you were a non-electrophysiology implanter, or particularly thoracic surgery, patients tended to have there was a higher procedural complication rate in this case. And in fact, the other interesting part of this, and this is a little off this topic, but they were also less likely to receive a CRT device when it was indicated. So saying, you got to look at your whole patient. You got to take care of the whole patient, not just be the surgeon in the lab, right? So you're going to want to, take that into account. And so we've heard, and I just felt, compelled, based on the objectives of this conference as they were outlined, is to mention, although we all hate to talk about this, we do this every day, but you hear such bad media on this topic. Device failures are uncommon. Let me just say that to begin with. And we have had these great advancements in technology over the 25 years of ICD use. And they are more complex devices now, and perhaps the number of recalls or advisories has gone up because they're more complex. I don't know, but I'm going to just show you a couple examples of what the advisories are that we're talking about. But when the New York Times and other newspapers and the media on TV, you start hearing about these horror stories, I want to show you what some of that is based on. So if you look at some of the data, and we will have more and more data as we go on with the NCDR registries, and that's going to be key to be able to track, to improve, and wherever we're at now. But I don't think it's as bad as the media says here. So if in this 12-year time frame, Dr. Maisel published an article in JAMA showing us that out of the reasons why devices were explanted, 2% were due to malfunction. Now, it doesn't mean necessarily it's a perceived malfunction, or it doesn't mean necessarily when you hear something's on advisory, or the word recall is kind of a misnomer. It's not like your car is recalled, bring it back, you take it out or fix it. It means that you might have to have closer follow-up. You need to be more aware of it. Remember, devices are lasting longer now than they did initially. And so we're probably going to see more and more of this, and we need to get a better handle on it. Obviously, anything that's man-made, anything mechanical could have some random failure. I guess it was estimated that could occur 1 out of 10,000 devices. And the FDA in this country is responsible for supervising the medical safety of devices, and it issues these advisories or recalls or whatever you want to call them if there is any part of the device is defective or could be a risk to health. It does not mean that the device should be returned. Taken out and returned, although I do need to say that we do like to return when we take devices out. We like to send them back to the manufacturer, even routinely, because if something comes up down the line, the Heart Rhythm Society, Dr. Al-Khatib has been very involved in that too, is really promoting that these devices get back in case there is an advisory down the line that the companies can look back and say, hey, yeah, how prevalent was that problem? And I'm going to show you, if you just type in on the internet ICD advisory or defibrillator advisory, some of the first things that comes up are the names of lawyers, right? So just to show you that basically, there's other motives out there, right? But here it says if you have one of these devices, you may be eligible for compensation. So, everyone wants a piece of this, right? So, but really, I think what's kind of hurt us, or not just us, but hurt patients potentially who aren't getting devices is because of some of these things. The New York Times, we all respect the New York Times, right? But when they start to talk about replacing a wire that might fail, we have to say the company, in this particular case, it was a lead advisory. Every company, let me preface it by saying, I tried to show different samples here, but every company has had advisories or recalls, and no company is ever going to be immune to this. But that they warned doctors that nearly 250,000 patients that a wire or lead connecting their electronic defibrillator to their heart might break. And so the patients have obviously questioned, and sometimes this, by the way, I remember one example, I was driving to work, and before my rep could even tell me, I got a page from a patient because this was out in the media already, somehow it leaked, and should they have this faulty wire removed or leave it in and hope that it doesn't fail? So what is the risk? But what's the risk of the failure? But not only that, what is the risk of replacing or extracting the lead? That has risk. So we need to look at the whole picture here, not just what we hear in the media. And this is just another example, another company, but here was a total of 10 confirmed malfunctions representing 0.032% of the implanted population of 31,000 devices. Do you really want your patients to be really scared about their device on a daily basis? We need to educate. We need to educate everyone. We need to educate the media, but there was no patient death or anything in this. And a lot of these, by the way, a lot of these advisories that come out all the time, we can reprogram certain things. They're not, with using new software. So it's not all really serious kind of things, but because of these advisories in the media, patients and physicians and referring doctors have questioned, should we really be doing this? Although despite the fact that I showed you all those great trials, despite the fact that we have more indications for devices now, really the referral for ICDs has plateaued. And I think really a lot of this has really been exaggerated for a lot of different reasons. We'll know more data, as I mentioned, with the NCDR registries and prospective registry enrollment will really tell us things about leads as well as devices now, and education, as I mentioned. So what are some of the advances? Let me just run through in the next few minutes that we have. What are some of the advances that we've seen? Well, I mentioned we implant things like a pacemaker, pectoral. They're smaller devices. We have biphasic waveforms. It's just the way we deliver energy that now we can be very effective in converting ventricular fibrillation in almost all patients with an appropriate safety margin with the device. So we can deliver energy more efficiently. We have that active CAN technology that also lowers that energy requirement. So it's not like years ago where we'd have ineffective defibrillation. That was not all that uncommon when we tested monophasic waveforms in the past. We have high output devices, 35 to 41 joules now. They're smaller and also deliver more energy. We can have other electrodes to lower energy requirements, and we have longer device longevity. I'm just going to show you a picture. This is just a patient of mine that had a subcutaneous array. So if for chance you had a patient, and we see this less often now, but that didn't have an adequate energy requirement to defibrillate, you could put this underneath the skin. And this is just one of the manufacturer's types where it has these 3 electrodes that that's incorporated in the defibrillation system to reduce the energy requirement. Longevity, and I actually, unfortunately, I'm old enough to remember the devices would not last. It would be 2 years, 2.5 years, the devices would be an elective replacement. So maybe we had less time to find problems with the devices then. But if you look here, this is one study that looked at the device longevity of single, dual, and cardiac resynchronization devices. But you look here, just in the single chamber device, we're way out many years. So, we're talking about, 4 or 5 years routinely, and many devices now can last 7 or 8 years or potentially more as time goes on. So they're lasting longer, and we're talking about cost, but again, remember that the devices will last longer, and the patients are younger, and they're going to live longer. This slide here just shows you that the single-chamber devices lasted longer than dual or CRT. Again, less leads to pace off of less energy consumption. The other really great thing is that we have remote monitoring capabilities now. We can follow people at home when they're in bed, and it's wireless. Now, all the device companies have wireless capability. And I'll show you something about that in just a second. We have newer lead technology that, as we're implanting leads in younger patients, we want to be able to remove it. And there's certain characteristics of the leads that may make it more easy to extract if we ever need to extract a lead in the future. New connectors, I'll show you a picture of that. And now there's even work being done, and I hear is close to being released on MRI capability. A lot of patients wind up needing an MRI, and we worry about having metal in the lead and also in the device, and there's been some work with that that hopefully will be routinely available soon. And then there's also some work with a totally subcutaneous device. A lot of companies are working with this, and one company has it in investigational studies now where there's no endocardial lead. So the remote monitoring, again, this is just what it looks like on all these transmitters, and people can keep it by their bedside. And those that have radio frequency capability through the device, if there's something bad that happens, say the lead fractures, that device, that will be transmitted to the home base, the electrophysiologist clinic or nurse administrator or the nurse person running the clinic will get the data, call the patient, say you have a problem with your lead. Before it becomes a clinical problem, we can detect it remotely. In addition, again, patients who travel, where I see patients that can travel 2.5, 3 hours to see me in clinic. They don't have to do that. We could do a lot of the follow-up and do 1 or twice a year follow-up in the office. We think it'll increase patient safety, and they like it. Patients like it. They feel like they're safe with it. And might impact on cost, I'm not sure yet, but we'll see. And it certainly optimizes workflow in our clinic. This is just an example of something picked up on early diagnosis of a lead failure. There was an aborted shock. There were these very short intervals here. This is what the device sees. And you can see this, you might not be able to tell, but this is actually noise. When you get all this junk in here, there's noise. This happened to be a lead fracture. You get the data from the device. This one was detected on this example down here a little bit later, but here you can see the impedance suddenly increases. But if you catch people right in here, when you start to get that jump in impedance, you could prevent inappropriate shock. So this technology has really revolutionized the way that most of us practice nowadays. In addition, you can get noise from insulation problems. Leads, they're man-made. There's a lot of wear and tear in that lead, particularly under the clavicle, so you can get breaks in insulation. This is actually someone who had a shock during sleep, and you can see here the first shock didn't work. And so, this patient was brought in and investigated. The patient was on amiodarone, had an increase in energy requirement. Luckily, the second shock worked, but so you get 5 or more shocks through the device if the first one doesn't work. There's also the other benefit, actually, and some of us use this for, and particularly if patients for some reason can't be on warfarin. That you could pick up asymptomatic episodes or mode switching. So you can go back and say, and this says here, how many days there were 6 hours of atrial arrhythmia during the day with a dual chamber device. And you can see this in a graphic format here. So you potentially can, the impact on safety of the patient. Other, just a technology that, may not be as fascinating to everyone in the room here, but, you can see there's a new type of connector where it's just one pin, so less bulk in the pocket, which might be beneficial for, small patients, young women or men even who might be cosmetically conscious. This is an investigational system, and all companies are kind of, I think, working on some subcutaneous device system too. But whether this will be good or bad, we don't know yet. It's under investigation where there's nothing in the heart. So there may be some patients who have contraindications for endocardial leads, a tricuspid valve, or some other reason. You don't want to put them under an epicardial procedure. Now, that this is just some of the initial work. It's just being investigated in this country, but this study was done in a small number of patients to show that it can just basically work epicardial. But we'll see where that goes. The only disadvantage, or several potential disadvantages, the device here is bigger, delivers a higher output, but also does not have routine pacing capabilities, so patients can't need a pacemaker. You can't have that painless therapy with anti-tachycardia pacing. So this may turn out to be some kind of little niche area for a device. So just to summarize and conclude here as we're ending, so I hope I showed you data. The evidence-based medicine and prognostic benefit of ICD has been well established, and this is one of the areas where we have multiple randomized clinical trials for primary as well as secondary prevention of sudden death. Overall, ICDs are reliable, and they certainly save lives. We're certainly not perfect, and we do have a failure rate which doesn't seem overly excessive right now, but obviously we should always strive to be better. And the numbers, as I showed you, some of those percentages for the advisories are really, we're talking about tiny, tiny percentages of chance of failure. So what are we going to do in terms of the future? Well, we need to improve risk stratification. Obviously, we'd like to be able to identify even a wider variety of patients who haven't really had that low EF yet. Maybe genetic testing or other modalities may be useful in that respect. And we also want to not put devices in for patients who will never use them. So we need to better work on risk stratification. And the other thing, too, is, and Dr. Al-Khatib did bring up in discussion here a little bit, but we want to talk more about any potential disparities or bias that might be related to ICD usage that we need to understand better and educate better. And this Sudden Cardiac Arrest Thought Leadership Alliance through Duke and through Dr. Al-Khatib's efforts will be key in this area, I believe. And device technology, again, we want even longer devices would be great, better reliability and performance, better arrhythmia discrimination to 0% inappropriate shocks would be great, hemodynamic monitoring of devices, and again, we're going to continue to monitor this no matter how, and now we have this mechanism that's a good mechanism through the NCDR. And that's essentially it.
Thank you very much.